Welcome to the Talk BD podcast, where we break down the science and strategies to live well with bipolar disorder.
A warm welcome, everybody. Today's episode, we have Dr. Trisha Suppes, professor of psychiatry at Stanford University, really a world-leading expert on the biology and treatment of bipolar disorder, with particular expertise in long-term medication treatment strategies for the condition, BD type 2, diagnosis, research on newer interventions like psychedelics for mood disorders, particularly in veteran samples. Trisha was chair of the DSM-5 Bipolar Disorder Subcommittee, past president of the International Society of Bipolar Disorders. Really, of all of the people, I think, working in bipolar disorders research and care, Trisha, you have some of the most wide-ranging expertise and also a huge amount of advocacy and passion for supporting women in research, people with lived experience, clinician scientists. It is a pure joy to have you on our Talk BD podcast today. Welcome.
Thank you for that very kind introduction. I'm excited to be here and look forward to chatting with you.
You have a lot of excitement and interest in bipolar disorders research. I'm just wondering where all of that began for you. I'd love to go back and to hear, where your interest in medicine and in psychiatry started and learn a bit more about what the backstory is there.
Yeah, there is a backstory. And I think I was interested in mental health from early on. There was no focus then on bipolar. The U.S. was very slow to begin to be aware of bipolar disorder, and there was much more focus on schizophrenia. So I think until I was a resident, I actually wasn't very conscious about bipolar disorder and people having bipolar disorder. And then I did my residency at McLean, which at that time was really one of the main institutions. There were so many great researchers there. And it was where some of the earliest medication studies were done. So, for example, while I was there, we had a compassionate use for clozapine for treatment-resistant bipolar disorder. And also, it was the first studies of Depakote, in particular Depakote or valproic acid or valproate loading for bipolar disorder mania. So there was a lot of focus, and I became aware that bipolar disorder was a thing. So I actually wasn't aware of that. And then I decided to go into psychiatry, and then I got very interested in bipolar disorder and really decided to make that a focus. So one of the things that led to that focus, one of my patients, call him Lou, was someone who, when he was on lithium, bipolar 1, did extremely well. You couldn't tell if he had an illness or not, which you see with some people. But so I was sort of asking, well, is lithium curative? But every time he would stop lithium, he would almost immediately develop a manic episode. So I asked myself whether lithium could be curative, or did it matter if people stopped and started? And that led me, in collaboration, particularly Ross Baldessarini was a mentor for me, to look through the literature to see in bipolar 1, people who'd stabilized, had clear bipolar 1 as diagnosed in the late 80s, what happened when their lithium was stopped. We did put a paper together where we found that lithium, if discontinued after stabilization, caused 50% of folks to relapse by 5 months and 95% by 5 years. And so that paper actually had quite a bit of impact, because prior to that, part of why I got into the question was when I went in the literature, some people said you should have drug holidays, some people said you don't need to take it forever, and so on. And so when I got into the literature and I did the analysis with Ross, what we found was, again, that high percentage of relapse. And the graphs were, quite dramatic. You can see the immediate drop-off.
Right. So we hear about lithium being called, the gold standard of treatment for bipolar disorder. Do you think that's the case at this point? What's it been?
Well, in 70-something, since 75, since it was rediscovered. Yeah, I think it should still be a foundational treatment. Like, it isn't going to be right for everybody, but I know there's a few folks I've had who are 7-8 years into treatment, and then I give them lithium and they go, oh, my brain feels better.
Right.
So I think, as you know, most folks with bipolar disorder, you're not going to get away with one med. So often you're balancing 2 or 3, and, you don't necessarily have to go to high levels on all of them. And I think one of the tricks about lithium is what you need acutely is not what you need when you're stable. I think that's an important element, because when you're stable, you're more sensitive to side effects and you don't need as high a dose.
So let's think about some of the other main treatment options that are available for people with bipolar disorder beyond lithium.
So I think if you're treating all the phases of the illness, for example, lithium and lamotrigine are a great combo. Also using the second generation antipsychotics, assuming the insurance covers them and they're approved, can also, some of them are really quite good with different side effects than the earlier second generation. So a lot of the earlier second generation have side effect metabolic effects and weight gain, and obviously that's not good. So the newer ones lend more towards like akathisia, but not a lot of weight gain. So
what's akathisia?
Now, akathisia is when you have this sense of inner restlessness and you can't sit still. So interestingly, back where I trained, people used to, when they saw patients with akathisia, they used to give them more antipsychotics. So that's actually making the symptoms worse. So someone else at McLean, Jim Lipinski, was the one who was able to sort of notice and say, hey, this is akathisia. We need to treat this a different way. So akathisia, you don't really see it as much with the newer meds compared to the first generation, though you can see it for sure. So I think most people start treatment as an inpatient, or if they're outpatient. So I think the initial treatments are based on what's going on. Mm-hmm. So if someone is depressed, maybe they're going to start an antidepressant with a mood stabilizer, or maybe just an antipsychotic with antidepressant properties. And then lamotrigine can be very useful, but that's more about preventing new depressions. It's not really a mood stabilizer. It's used that way a lot. It's not really a mood stabilizer, though. Great for preventing new depression, though.
And a bit of a deeper dive into antidepressants. We hear a lot about potential for switch in antidepressants. Can you unpack what that means and what your understanding of the evidence is around that in particular right now?
So one thing that can be confusing about switch, it's one thing to get a little irritated and revved up from antidepressants. True switch means you stop the antidepressant and, a week later or 5 days later, you're still having hypomanic or manic symptoms. So, beyond the half-life of the antidepressant. So getting a little revved up is not the same as switch.
It's an important clarification.
Yeah. So first of all, that idea came from papers in the 70s and 80s, a lot of them out of Pittsburgh, where people were given tricyclic antidepressants. Those precede the SSRIs, NRIs, so that precedes fluoxetine and so on, venlafaxine. Or they were giving MAOIs, which are not even used as much as like transcyclamine, I think, but with no mood stabilizers. And in those situations, they did get a lot of switch. But recently, it's become clear the amount of switch you get, particularly from SSRIs, is quite limited. There were studies with quetiapine where they had, for depression, where they had an arm that was an SSRI alone, and they didn't get a lot of switch, in fact. Now, I think Edward Vieta and crew out of International Society of Bipolar Disorders did a really excellent consensus, which had a simple remark, which is you should never use antidepressants alone in folks with bipolar 1. And in bipolar 2, there's less certainty, and they may be helpful to some people as monotherapy. I do think that reflects the practice. That was good advice, in my view.
Mm. For some people, medications that have worked well in the past lose their effectiveness over time. What's the reasoning behind that?
So it's an interesting question, because I think in part it depends on drug class. So as an extreme example, for folks who are on clozapine, either for mood stabilization, it's actually probably one of the best mood stabilizers we have out there for like bipolar 1 who just don't stabilize. Has lots of side effects, and it's not a simple med to take. People who stabilize on that drug, it never seems to go away. So it's very unusual. However, antidepressants, for example, and even some of the other mood stabilizers, there seems to be like not exactly a wear-off effect, but it doesn't, not in everybody, but in some people, it just doesn't seem to work as effectively after a while. I don't think that means they don't need a medication, but that particular drug, I think there are different strategies. You can go up, you can also switch drugs. So it's real. I don't think people are imagining it. And some of it's the illness itself is changing over time, and the brain is also changing over time. So neither are static. And it can be why one medication that solved everything at 25, at 40 is no longer as effective.
Yeah. So you talked about different pharmacological or medication options for people with bipolar disorder. Can we turn for a minute to think about different types of treatment that are available or showing promise, perhaps, beyond pharmacology or medications?
Sure. Yeah, I think that if the society and your insurance can support it, I think that psychotherapy of all sorts is a really helpful augment to people. So whether that's interpersonal social rhythm therapy, I think you had Holly Schwartz on recently, and she did a terrific job of describing that, or even psychoeducation, which is showing that increases people's adherence. I feel like the therapy around the education is important, but also sometimes more classic psychotherapy can be important because these are devastating illnesses. People have an idea, they're extremely high functioning sometimes, and then they have their first manic episode, and sort of their sense of self and who they are, they need to go back and kind of work through that.
So in an ideal world, we have, for many people, medications or pharmacology going hand in hand with psychoeducation as a starting point, self-management, information and strategies, maybe specialized psychosocial treatments, psychological treatments. On top of that, what about other aspects of healthy behaviors or care, like diet? Let's begin with diet. What's your take on the evidence currently?
Well, I think that first I would actually like to just back it up and say everything that keeps everyone healthy is also useful to everyone who has bipolar disorder. So, you shouldn't smoke for sure. And alcohol should be very limited, if at all. And hopefully you're eating a more or less healthy diet. So I feel like that's all of that. Sometimes there isn't enough focus on just a general, quote, healthy lifestyle versus taking medicine. And the medicine is where you start. It's not where you finish to have a full life with, good social engagement, support group, and so on. There's been some recent talk about the ketogenic diet and whether that might be helpful to people. I think the jury's still out on that. My guess is it will be helpful to some people. Because if you remember in epilepsy, there have been use of the ketogenic diet as an anticonvulsant effect. And so since anticonvulsants can help people with a bipolar brain, I don't think it would be a big leap to think the ketogenic diet could be helpful as well.
You mentioned alcohol, minimal, if at all. What about cannabis? There's a question that comes up again and again for us.
Yeah. So cannabis, when I went in recently to look at how much literature there was, I was a little surprised there really wasn't as much literature as I thought there would be. So there is some literature around that it might hasten onset. It might even cause onset, but really you don't really know. And I think, the question might be people are doing it because it makes them less anxious, but in the long run, is it going to make the co-occurring anxiety disorder worse, which could in turn worsen the bipolar disorder?
And then let's look beyond pharmacological, psychosocial interventions, sort of, healthy lifestyle stuff, and start to think about some of the newer treatments that are being tested for bipolar disorder. Well, they're not new treatments. Let's look to ketamine. Ketamine is an anesthetic that's been used for a long time, but has more recently been explored in terms of major depression, a little bit bipolar disorder. Do you have thoughts on where the ketamine evidence is at?
Ketamine is approved for major depression. I don't think it's approved for bipolar disorder, which is too bad because you would use it exactly the same way for folks who have unipolar depression, right? And there have been some case series and studies looking at the effect of ketamine on acute suicidality and depression. And it is found to be as helpful, I think, for folks with bipolar as for unipolar. And I'm not aware of any difference in bad outcomes. One of the issues, though, with ketamine is you have to keep doing it. It's not like it's one and done. I think one of the other modalities that's interesting is rTMS and other short, rapid-acting neurostimulation treatments. So rTMS has been looked at in bipolar disorder. There was one negative study actually out of Vancouver. And now there's also one, and that one was not your standard rTMS. It was rapid multipulse theta bursts. And now there's one coming out also of Baltimore, which is multi-site, which does show good efficacy. And in fact, for folks with bipolar, the more treatments you do, the better depression. So I think I feel like we should know more about some of these treatments, but we don't. And I think they're still learning. And there's also the neurostimulation technique, which is not used a lot, is vagus nerve stimulation. Are you familiar with VNS?
No, I'm not. Fill me in.
Well, and I think you would be one of most, including most psychiatrists. It's understudied and underused. So VNS is there's actually a pacemaker implanted here, and they run a wire up through your vagal nerve. And then they know kind of which parts of the brain it stimulates. It's an older, very effective treatment for treatment-resistant seizures. Again, a stabilizing thing. Obviously, you need a neurosurgeon, and your psychiatrist is not going to implant the pacemaker. But what happens with the VNS is the longer someone is on, the better it gets. So it's not curative, but instead of sinking to the sub-basement number 5 with depression, they're going to sub-basement number 1. And it seems to sensitize the brain to be able to respond better to medication. So something that wasn't working before with the VNS can be helpful. It's an interesting treatment.
One of the issues with ketamine, as you said, was its transient effects or the fairly short term. You need to do it frequently. What about the TMS and brain stimulation type interventions? Is it as frequent a treatment intervention regimen that's needed, or?
I think we don't fully know. My guess is it'll be like electric shock, which is with electric shock, you can get remission, but then at some point you have to do maintenance. And maintenance ECT is a little hard on the brain, whereas rTMS, you don't need anesthesia. There's relatively few side effects. So my guess is you're going to end up probably needing some maintenance. I don't think those data are in yet.
I'm really glad you raised ECT as a treatment option. There's a lot of stigma surrounding ECT, and I'm wondering what your take is on where it fits as a treatment option at this point.
Yeah, so I think ECT is underused, just flat out. So there is good data to say that being very severely depressed or very severely manic for long periods of time is very hard on the brain. So what ECT does is in 3 treatments, it can break a cycle like that. And the course of it might be, 3 weeks of 3 times a week, say. But that can bring someone's brain back to stability and normality. I don't think you want to use it as an ongoing treatment because it can be hard on memory over time. But as an acute life-saving treatment, I feel like we underuse it.
Particularly people who are really at risk of suicide or self-harm.
Also suicide, yeah.
Which brings me to the question we get a question again and again around severity of illness. It often comes in from family members or loved ones of people with bipolar disorder. And frankly, I really never feel like I have a good answer for the question. The question is, my family member or loved one is very ill, lacking in insight. They don't know how ill they are. But I can't, I don't know how to get help for them without that insight piece into their well-being. How would you respond if that family member was in your office? What would your response be, Trisha?
Well, and I've been in that situation. So it's very hard, particularly this occurs earlier in the course, usually. I think it's extremely hard because that person who has the illness will immediately stop taking drugs. And they have no memory, particularly, let's say, bipolar 1. People seem to remember depression. but they don't always remember mania. And that's where people can engage in very risky and unsafe behavior. So someone who has come out of mania and is now fairly stabilized, and they're going, I don't have an illness. I think that's a very tough situation. I mean, am I going to talk them into the fact they have an illness? It's unlikely. There was a very nice paper, again, this came out of McLean, talking about how the lack of insight was comparable to a parietal stroke. So in a parietal stroke, like that speck right here, you can think you've lost your left arm. Like it will cease to exist for you in your brain and you have no insight. So you can look at it and you won't think it's your arm. So in the same way, if someone has bipolar disorder and they have zero insight, it's very hard to work with. I remember one case in particular, quite a many years ago, I was training, and it was a woman in her 40s who had zero memory when she was manic and, still was working, had a close family, very supportive, who was working with her. She actually agreed and had them take a video of her when she was manic that she would look at to remind herself when she wasn't, to encourage her to take her meds. Now, I think even that doesn't always work. But you hope, I think it's, if they really don't think they have an illness, it's very hard, I think. Are they going to want to go to peer support groups, for example, with other people who have this when they have no insight? Mm-hmm. It's very hard, I think. I wish I had a simpler answer.
And maybe sometimes to do some sort of cost-benefit analysis if relapse did occur, to look at the consequences of that for school, work functioning, whatever they care about in their lives, and to sort of weigh up, the price of ongoing medications, the sheer hard work it takes to manage bipolar disorder well for most people, because it is arduous work a lot of the time, not always continually, but often in the early stages.
Well, and later too, because, the brain, let's say you get a great combination, the side effects are not, they're okay. You always have to ask about from the person's perspective, if these are side effects you can live with. It doesn't matter what I think. It matters what they think. But let's say you've got that going well. We all go through physiological changes as we age. And particularly the bipolar brain, I feel, can be more susceptible to abrupt changes. It's sort of built in. And folks with bipolar like me or anyone, as your brain ages, what you need is going to change. So I think it's really important when people are treating bipolar disorder to realize you're not just going to get one formula and be done. That will not work.
Let's go back to the question of one of the perennial or evergreen questions we get, which is, will I need to be on medications for the rest of my life? What would your standard response be to that question?
So I think you want to distinguish bipolar 1 and 2. I really think they're really quite different illnesses. So if you're talking about bipolar 1 and someone has already had 2 manic episodes and maybe depression, but at least 2 manic episodes, I think the high probability is they're going to have to take medications long term. Now, I think there's still a lot of debate if somebody's been quite stable, sometimes in Europe, after 10, 20 years, they may go down. But I think the general consensus is globally that if someone is really confirmed bipolar 1, they should stay on a stabilizing medication. Again, epilepsy. You could come off of it, but if you really have a seizure disorder, you will get a seizure. Your brain, that's what's going on with the brain. Now, bipolar 2, I think, is a different question. So in bipolar 2, if somebody is really stabilized and not, the tough issue with bipolar 2 is depression. And people get depressed and it's very enduring and can be very hard to treat. But if someone is not depressed and feels like they've been stable a long time, I feel like the risks are quite a bit less if you're having a trial with lower or fewer meds. And, there was that study that Dr. Schwartz spoke about where they looked at IPSRT versus quetiapine for bipolar 2 depression, and they were fairly similar. Now, relatively short-term trial, it's not big. Those are very tough trials to do. But I think the question about long-term treatment with bipolar 2 is not as crystal clear as bipolar 1. There was a really good study out of I think it was the Swedish bipolar database, where it was about 8,500 people, and they looked over 9 or 10 years at bipolar 1 versus 2. and the degree of illness, suicide risk was very similar across the two illnesses. So one should not look at bipolar 2 as a lesser illness. To be honest, it's actually can be harder to treat bipolar 2 than 1. It's not as straightforward.
Well, it often takes us a long time to get the diagnosis right of bipolar disorder 2, and that's not a fault on the side of the healthcare system or the clinician or the patient. The myriad factors for why it still takes on average 8-9 years for us to detect bipolar disorder fully. But we also know from research that much of the disability, quality of life, impairment is associated with the depressive phases of the condition. Mania can wreak huge havoc on finances, on social relationships. But when we look at impacts, as I understand the data, on quality of life and functioning over time, depression is one of the big drivers of that, right?
Yeah, and mania can be more dangerous. I think people do more dangerous things in different quadrants, but depression is the much more common denominator. And if you look at, there's a number of different pie charts where if you look at the amount of time euthymic versus hypomanic or manic and depression far outweighs hypomania or mania. So, and I do think that it definitely impacts people in all domains.
What would you do if you had a magic wand in terms of really changing our system to be able to detect bipolar disorder type 2 or with more speed, more effectively? What could we do at a systemic level that would make a difference, do you think?
It's an interesting question. I think, first of all, it's important to realize people who have bipolar disorder, whether it's 1 or 2, they don't recognize hypomania. So they don't know. Someone says, do you have hypomania? And they're going, I don't know. I have no idea, because it's part of their life. It's part of what their experience is. So they don't have a label for it. Depression, it's really clear. They feel crummy. They don't get out of, whatever the symptoms are. But hypomania might even be seen as a relief. So I did a study quite a while ago looking at the large Stanley database, where it was about 14,000 visits, 900 people. And this was a great network study. Mark Fry, Susan McElroy, Bob Post, and as well we had European collaborators. And what we found in that data was that if you're hypomanic, you're actually more likely to be dysphoric. In other words, not a happy hypomania. In other words, what I talk to about patients is irritated, like they're energized depression. They can relate to that. Like, I'm not depressed, but I'm still depressed, but I'm moving. So system-wide, the only thing I can really think of is if there was a really intensive education program at the provider level about hypomania, because that often will also be the first symptom of an evolving bipolar 1 disorder. Hypomania. People just don't spring into mania often. And in fact, again, in the Stanley database, 50% plus first episode was depressed. That lends itself to the misdiagnosis, I think.
This conversation makes me think about mixed states as well. Yeah. I wonder if you could unpack a little bit what a mixed state is in the context of bipolar disorder.
So DSM-4, mixed states where you had to meet full criteria for mania and full criteria for depression, which occurs, but that's much more rare than people having a kind of admix of symptoms. In other words, they're meeting criteria for mania, for example, but then some of the time they have, or even most of the time, they have depression symptoms as well. So they could be manic, but they could be despondent at the same time. And those depression symptoms may vary on a daily basis, but you still got enough depression symptoms that you're saying, oh, this is mania with mixed symptoms. And similarly, in a depression state, a mixed symptom would be you're very depressed, but now you have tons of energy and you're extremely irritable. As a couple examples, or you're not sleeping as well, but you have no energy, that kind of mixity.
An unpleasant, deeply unpleasant state for a lot of people.
Absolutely.
Hey, we haven't talked about psychedelics yet.
Yes.
I would love to take a bit of a dive into, let's start with psilocybin, the active compound in magic mushrooms, more commonly known. You've been doing work in Veterans Affairs samples and people with mood disorders. Does that include people with bipolar disorder or more kind of major depression?
So the thing we did in Palo Alto is with folks with very severe treatment-resistant depression. Most of them were co-occurring with PTSD, which is not surprising in a military sample. The PTSD did not impact whether they responded to the psilocybin. But I also have a close collaborator, Scott Aronson, and he did a bipolar 2 study, of which I think I'm a co-author on his paper. It's the first published bipolar 2 study. Now, Josh Woolley at UC San Francisco is doing another bipolar study. I think you're a consultant on that. Right. And I believe you told me Lakshmi Yatham in Vancouver just got a grant to do more on bipolar 2. So it's great. So in Scott's study, it was a one-time dosing. It was not treatment-resistant depression like what we did in the vets and he did in the civilian. It was depression, and an episode of some duration. And they dosed about 15 people. And I thought the results were very surprising. It was a very unusual rate of remission and response. Again, I think the bipolar brain, I wasn't surprised in the sense I think the bipolar brain can shift a little bit more if you give it a chance, right? You have to find I always think of it as like you're cracking the diamond on the head to find the right combination or what are the right approaches to help somebody really stabilize. So I think it's going to require some longer term follow-up. I also know some of the other studies may not be finding quite the same rate of remission and response. Now, having said that, I do think it's important to realize that we're always focused on response and remission, but how about the people who don't respond? Mm-hmm. And there's always at least about 30%, if not more, once you're out to 12 weeks and longer. And many of these people go into studies with psilocybin expecting a miracle. And what if you're one of the 30, 40, 50% who don't respond? That can be really devastating. And I feel, unfortunately, the media is still doing somewhat of a disservice. Now, I think embedded in your question was about the use for psilocybin. So I think I am very excited by the bipolar 2 studies because I think in bipolar 2, if you're discontinuing drugs that could have interaction with the psilocybin, like some antidepressants, of course, you have to be very careful. We had to discontinue drugs in our study, about half the people. You have to really, be in good touch with them, be sure they're doing okay, because even when they aren't working, they can still have an effect.
And we have to think about the effects on sleep in particular and bipolar disorder of these types of interventions. What about microdosing? You got thoughts on microdosing? That's another question we get a lot through.
No, I think microdosing, the studies I've seen, and there have been some nice ones. Harriet DeWitt has done some good studies in Chicago, and also Robin Harris. There hasn't been separation from placebo and the microdosing.
And what kind of samples were those studies?
LSD, and they were up to 100 people. They weren't small. Some of them were good placebo crossover studies, I thought, where the patient was masked. They just really didn't know what they were getting. And in those studies, there wasn't a difference. Everybody reported some benefit, but there actually wasn't difference between placebo and microdosing. So one of the things I feel that we're learning from psychedelics that we haven't yet started working on is the power of the mind. So if microdosing is as effective as a placebo, that's interesting. And if we're getting surprising results with psilocybin, if somebody stays well for 9, 10, 12 months who've been ill continuously for 10 years, I think that we need to sit up and think about what that's telling us. It isn't always the drug. It might also be something going on, remodeling in the brain. There's more to come. I think people are not done looking at microdosing. And LSD in particular is easier to microdose because it's such small quantities and it's synthetic. Now, we didn't talk about MDMA, which the chemical name, somebody told me I should be sure to always be able to say this. It's 3,4-methylene dioxymethamphetamine.
Well done.
That's MDMA. And MDMA is probably going to be approved, barring unexpected hitches, by the FDA. It'll be rescheduled, assuming there aren't big hitches. They've had 2 successful phase 3 studies, which is the requirement to petition the FDA for approval. And if it's approved, it would be for PTSD. Mm-hmm. So the fact it is an amphetamine, again, would suggest that in bipolar disorder, it should be used with caution.
But watch this space.
Yeah, I think so. I think there's a lot more to unfold with MDMA. Again, you're decreasing meds that could interact.
Right.
So, but I think the space is not done. I mean, we're at hopefully the front edge of about 20 years of research. And I think there's just a lot more to learn. I just think it's important to remember not everyone's going to respond. Some people will respond, and we're just still learning about who responds and why do they respond. We don't know yet. So it's an interesting set of studies for sure.
So would that be something that we'd call kind of personalized medicine approaches, thinking about,
Yeah, I think that would fall under personalized medicine, because if we can predict who will respond better than someone else, I think that's can be a big step forward.
Another question we get a lot is that I feel like my clinician feels it's safer to keep me a little bit depressed, whereas where I want to be is back to my usual self. Do you think that's something that happens for us as clinicians, as a clinical community?
So I'm not sure people are going to get back to their usual self, but I personally don't think it's good enough to be a little depressed. I don't, to me, that means they're not adequately treated. So who they are in their usual self may not be the same as they were before they had the illness evolve and develop. But I also don't think it's okay to keep people a little depressed because it may feel safer. To me, that's not a good quality of life. And I appreciate your focus on quality of life, because that really highlights, just like I don't think it's okay for people to stay a little hypomanic, because that means their brain is unstable. And a lot of folks would prefer to be a little hypomanic, understandably. I would like that too. I mean, it's understandable. But it also means if you're someone with bipolar disorder and you're prone to greater instability, that when you have hypomania and you're unstable, that puts you at risk for more depression or mania or just more destabilization.
So it's understandable, but not sustainable or necessarily safe.
One thing we haven't really touched on too much is that bipolar disorder has the most co-occurring conditions. Bipolar disorder doesn't travel alone. It travels with anxiety disorders, with phobias, with PTSD, among others, including eating disorders. So bipolar disorder, you can't just sort of say what's going on with your bipolar disorder. I think you have to be also talking with people about other parts of their experience. Because I remember one person I'd been treating for a long time, and then I finally was asking more questions, and it turned out there was this whole other, they were having panic attacks they weren't telling me about. And they were not telling me because they didn't view me as the person to tell those things. And yet, I'm trying to organize their overall treatment. So it's important with bipolar disorder to also look at what are the friends they're traveling with.
So imagine yourself in a situation where somebody who's 21, 22, just had their first manic episode. So clear diagnosis of bipolar disorder. They're that person who's looking ahead thinking, okay, I may have to take medications the rest of my life. They've read the misery statistics about outcomes with the condition. You have your opportunity for your first sort of, they're not an inpatient anymore, they're an outpatient, your first clinical visit with them as an outpatient. What's your messaging to that person at that point?
That I think with good management, both for themselves, management of themselves, and with some good medical care, they can lead fully normal lives. That there's a very high probability their illness can be managed in a way that they're not suffering from side effects. They're not having acute episodes. People actually can't tell they had bipolar disorder. It doesn't have the stigmata of schizophrenia, for example. So I think the message is even though the original dreams you had you may have to come at them a little bit differently, there's still a lot of room for a fully rich, usual life.
Trisha, when you look back over your career, what's some of your study or publication that you're most proud of?
Well, that's an interesting question. So the one that had the most impact was probably the first one. I've always thought it was terrible when you look at like Hollywood and you see people, their best work was at the very beginning. And I remember I went, I never want to do that. And then I published that study and I went, okay, that's it. I'm probably never topping that. And I would say at some level that's true. Other than that, the work I really felt that had an important impact was the study we did through the Stanley data showing that hypomania is not euphoric, that you shouldn't be just if it wasn't euphoric, people weren't treating it like hypomania, which then led to impact and diagnosis and management. So through the Stanley study and then through my work on DSM-5 with other databases also showing we're able to shift the diagnosis of mixity, actually, both in bipolar disorder and major depression. So to me, that was a fairly significant thing to do.
Mm-hmm.
Do you have any favorite papers?
I'm not one of those people who, honestly, I remember talking with one of my mentors when I was early in my career and asked him, do you look back on those early papers you published in your career and think that they're really rubbish, which is what I do. I look back on something I wrote 6 months ago. I'm like, oh, you could have done that differently. Not in terms of the research, but in terms of the writing. So I never go back to a paper and think, oh yeah, I nailed that.
No.
But I do feel like I'm most proud of creating a space for people through CREST-PD to get involved in research in a different way. And I think we don't always value, we would often call that community service when we judge, whether scientists are ready for promotion or tenure. And it makes me, I'm proud of that the impact of that work. And I see legacy in that now in a different way. So I think, I don't think it's just about the experiments or the papers. It's also about our interaction with patients and that being able to support and help people on their journey. To me, that has a lot of meaning and importance. It's been such a treat to have some time with you today. Thank you so much for joining us for this episode.
Thank you very much. Appreciate it.